Good morning, everyone, and welcome to another TIRO by MDS webinar, where each week we bring together leading experts to discuss the latest advancements in thyroid cancer and thyroid disease research. My name is Eyal Robenstock. I'm an endocrinologist and thyroid cancer specialist, and I'll be the host of today's session. We're joined by two distinguished thyroid cancer experts from Brazil. First, Dr. Leonardo Barbi Walter will present his study on active surveillance of cervical metastasis in patients with differentiated thyroid cancer. Dr. Walter is an endocrinologist and with a master's degree in science and PhD applicant at the Universidade Federal do Rio Grande do Sul, Porto Alegre, Brazil. Hope I said it okay. He's a member of the thyroid unit of the hospital, and he focuses on clinical research on thyroid nodules and differentiated thyroid cancer. Dr. Walter will be followed by a discussion by Dr. Rafael Scheffel, who will present his perspective on the topic. Dr. Scheffel is an esteemed associate professor specializing in thyroid studies at both the hospital, the Clínicas do Porto Alegre, and Department of Pharmacology at the Universidade Federal do Rio Grande do Sul. He serves as the vice president of the thyroid department at the Brazilian Endocrinology and Metabolism Association. Before we start, be sure to tune in to Voices of Wisdom, our podcast dedicated to medical professionals in thyroid cancer treatment. Each month, we explore expert insight and groundbreaking research. Catch new episodes every third Tuesday of the month to stay ahead of thyroidology. It's available on Apple Podcasts, Spotify, and any of your favorite podcast apps. Tune in and follow our podcast today. Dr. Walter, the stage is yours.
Okay, initially, thank you. Good morning, everyone. Thank you, Dr. Robenstock, for this opportunity to present and share our paper and discuss. We are very excited about it. And today we will discussing the paper entitled Active Surveillance of Cervical Metastasis in Patients with Differentiated Thyroid Cancer, a Retrospective Single-Center Cohort Study. These are our disclosures and the funding of the study. And we are all familiar with the epidemiology of thyroid cancer. We have seen in the last decades an increase in the incidence of new cases of thyroid cancer, while the mortality rate has maintained low, suggesting that a large proportion of these new cases are due to indolent diseases, patients with very low disease-specific mortality, and a large proportion of these patients are potential candidates for active surveillance as a therapeutic strategy. We know that despite the mortality rate is low, the morbidity rate could be high. 10 to 20% of these patients will recur. In 3 out of 4 of these cases, it will be a cervical lymph node metastasis. And the big question here is, how should we treat properly these patients? We know that the standard of care, the standard of treatment is the neck dissection. The ATA guidelines recommended to us to evaluate with fine needle aspiration biopsy lymph nodes, the central neck larger than 8 millimeters, and in the lateral neck larger than 10 millimeters, and the amphiform surgery. We know that radioactive iodine is probably unlikely to provide benefits. We have now minimally invasive therapies such as chemical or thermal ablation, including ethanol ablation. And as an alternative, we have active surveillance. So we came to our last guidelines from the ATA to see what do they recommend. And they say that smaller lesions are probably best managed with active surveillance, reserving fine needle aspiration and subsequent intervention for documented structural disease progression. However, they do not clarify for us what should be the parameter to define structural disease progression. Also, they say that through thorough patient and multidisciplinary collaborative discussions, metastatic nodes larger than 8 to 10 millimeters can be carefully observed in properly selected patients, with surgery being offered if they progress during follow-up. But what is the meaning of selecting properly patients for active surveillance? We still don't have answer for this both questions. Who treats these patients knows that it is not uncommon for the same patient to undergo more than 1, 2, or 3 cervical surgeries. Actually, 28 to 38% of patients develop recurrence after a therapeutic neck dissection. And we have to remember that these repeated interventions can add morbidity to generally indolent diseases. And there are several complications that can be possible, such as hypoparathyroidism, cervical hematoma, vocal cord paralysis, dysphonia, and anxiety. So moving on to our study. This was published in Thyroid last year. Our objective was to evaluate the outcomes of cervical lymph node metastasis on AS and search for factors associated with disease progression. We performed a single-center retrospective cohort study at the Outpatient Diagnostic Center of our institution, the Hospital de Clínicas de Porto Alegre, Brazil, between 2013 and 2021. This unit is a multidisciplinary unit with simultaneous evaluations of radiologists, pathologists, and endocrinologists. Our population was adult patients with differentiated thyroid cancer and biopsy-proven lymph node metastasis selected for active surveillance. We included patients with metastatic lesions less than 2 centimeters in the maximum diameter, patients who had total thyroidectomy, and who completed at least 6 months of AS. We excluded patients with aggressive histology, lesions with proximity to or invasion of cervical noble structures, and patients under systemic therapy or radiotherapy or a history of these treatments. Our protocol involved semi-annual ultrasounds with the same radiology team, and then annually if there was lymph node stability or reduction. And we performed twice-a-year measurements of TSH, thyroglobulin under levothyroxine suppressive therapy, and thyroglobulin antibodies. And all patients were treated with levothyroxine suppressive therapy with a TSH target of less than 0.1 nanograms per milliliter or 0.1 to 0.5 if there was atrial fibrillation. Our primary outcome was disease progression. This was defined as lymph node increase in at least 3 millimeters in any diameter or new cervical metastasis confirmed by fine needle aspiration. Here we have the flow chart of the study. We had 145 patients with biopsy-proven cervical metastasis from differentiated thyroid cancer. 104 of these patients were referred to surgery. 19 had larger lesions, five of them had aggressive histology, and 1 patient had cervical radiotherapy. 79 patients met inclusion criteria for AS, but preferred immediate surgery, resulting in 41 patients referred to AS and 40 patients that completed at least 6 months of AS. Of these 40 patients, 14 evolved to disease progression and 26 remained with stable disease. Of the 14 patients with disease progression, 6 remained under AS and 9 were referred to surgery. 8 were referred to surgery. 1 of the stable disease group was also referred to surgery due to patient preferences. And 8 of the 26 patients with stable disease also met a secondary outcome of ours that was disease reduction. This is an outcome that we define as a reduction of at least 3 millimeters in any diameter without increase in the other dimensions of the lymph node. Here we have the analysis of both populations, the population that went to AES, the population that went to immediate surgery. The age was similar between the groups, 47 years old. The majority was female sex and had papillary thyroid cancer. The majority had a stage 1 disease of the HJCC staging system, the 8th edition, and an intermediate risk of recurrence from the ATA guidelines classification. And as expected, the dimensions were different. The patients that went to immediate surgery had larger lesions, 1.7 centimeter in the maximum diameter, the immediate surgery, and 0.9 centimeters in the smallest diameter. And in the AS group, it was 0.9 and 0.7 respectively. Both the populations have a reablation rate similar and similar rate for previous lymphadenectomy for recurrent or persistent disease. We saw a tendency of higher thyroglobulin at metastasis confirmation in the immediate surgery group, 5.6 versus 2.2, and had a higher positivity rate in the of the thyroglobulin antibody, 25% versus 10%. The interval between thyroidectomy to metastasis detection was different between the groups. The AS group had a median of 44 months versus 27.5 months in the immediate surgery group, and the time under active surveillance was 27.5 months. So we move to our comparison between the disease progression and stable disease groups. We performed this analysis to find any predictor of disease progression, but we found no differences between the groups. The variables were all similar between the groups. Of note, we saw a tendency of higher rise in the thyroglobulin of at least 0.5 nanograms per milliliter in the disease progression group. 50% of these patients met this criteria versus only 30% of the stable disease group. However, this was non-statistical significant. Consider evaluating the patients who met the primary outcome. Half of these patients had the disease progression criteria due to lymph node increase, and the other half of these patients had new cervical metastasis. The median time for the disease progression was 15.5 months. Here we performed a Kaplan-Meier analysis for cervical disease progression-free survival, considering the point of the evaluation with fine needle aspiration, confirming malignancy until the disease progression, or the last follow-up, and we had a median of cervical PFS of 51 months. Here we discuss the surgical outcomes of these patients. 9 patients were referred to cervical dissection. The indication was disease progression in 8 patients, and 1 patient chose to operate despite a stable disease. The median time for surgery was 20 months after the evaluation with fine needle aspiration. And interestingly, we had a very low complication rate. We had only 2 cases of transient complications, 1 case of seroma and 1 case of dysphonia. Both cases had spontaneous resolution in less than 6 months, resulting in a permanent complication rate of 0%. And 42.9% of the patients with disease progression, they continued under AS, mostly due to the disease low volume and unwillingness to undergo surgery. Looking out here, of the 6 patients that met the primary outcome of disease progression and were not referred to surgery, 5 of them met the criteria of increasing 3 millimeters, and one of them had the criteria due to new cervical metastasis. This one patient was the only patient who had systemic progression. He had lung and cervical metastasis, and was on consideration for TKI, the systemic therapy, at the end of the study. And these 5 patients who met the criteria due to increase in the lesion, one of them refused to undergo a new surgery due to vocal cord paralysis, and one was under investigation for primary lung cancer. These 5 patients remained under AS and did not show another disease progression. They kept low volume disease and demonstrate to us that even these patients that show the disease progression, the progression is very slow during time. Moving on to our discussion, we know from qualitative data that there are some challenges of implementing AS in differentiated thyroid cancer. This came from a study of Janssen published in the BMC Cancer in 2021. We know that are some factors related to the patient, such as special beliefs about cancer. One example here is the thinking that if you had a diagnosis of cancer and do not undergo immediate surgery, the surgery would be much more aggressive, and the oncological outcomes could be worse. Also, we have factors related to the medical team, such as obscure protocols for AS and also lack of data supporting AS. In fact, when we look at previous studies with AS for cervical recurrences of DTC, we found very few studies. We know that active surveillance for primary lesions of thyroid cancer are growing. There are several studies and guidelines nowadays, but studies for active surveillance for cervical recurrences, we don't have so many. I will highlight some of these studies right now, and but they were all retrospective single-center studies with generally small populations. So we came to the first one. This was a study by Hovenschock, published in the JCM in 2012. It was performed in New York. They included lesions less than 2 centimeters eligible for AS, had 133 patients and a median follow-up of 3.5 years. They included only ultrasonographically suspicious lesions. They did not perform fine needle aspiration routinely in all of these patients, which could be a potential selection bias because some of them may have not malignancy. However, we have to remember that the ATA guidelines do not recommend that we should perform fine needle aspiration biopsy if we will not change our management of these patients. We will not recommend surgery. And the primary outcome was 3 millimeter growth. They performed an analysis comparing patients who had the disease progression, growth less than 3 millimeters, and they also performed a secondary analysis of patients who met the outcome of growth more than 0.5 centimeters. The outcome of growth more than 0.3 centimeters was met by 24.8% of these patients, and 11.3% met the secondary outcome of growth larger than 0.5 centimeters. They found several predictors of disease progression, such as male gender, such as the size of the largest lymph node. Generally, smaller lesions had higher rate of disease progression. Thyroglobulin increasing 0.5 nanograms per milliliter. lesions avid for FDG, and lesions with increased vascularity on ultrasound. But these were all univariate analysis. When they performed a multivariate analysis, non-predictor came as an independent predictor for disease progression. We move now to the Japanese study. This was a study published by Tomura and Ito in Thyroid 2016. Here they included larger lesions, lesions less than 3 centimeters. We have to remember that we have data showing that lesions, cervical lesions larger than 3 centimeters are associated with high recurrence and possibly worse survival. These patients are considered high risk of recurrence in the ATA guidelines. And so that's the main reason why you probably won't see any studies of AS, including lesions larger than 3 centimeters. They had 83 patients and a median follow-up of 86 months. And they use an alternative primary outcome. They included a criteria of time. They analyzed patients who met the criteria of 3 millimeters growth per year. They had 20.5% of the patients in the cohort that met the primary outcome. And they also found some factors associated with this outcome. Here, older patients had higher odds of disease progression and also larger lesions. But here, this is also univariate analysis. When they performed multivariate analysis, any of these predictors came out as an independent predictor for lymph node growth. And they also reported the rate of new cervical metastasis, an outcome that was met by 10.5% of their population. They also performed overall survival analysis and showed that the patients who met the primary outcome had a lower survival rate than the patients who not met the outcome. We move on to the Portuguese cohort, a study by Maciel and Leite, published in Clinical Endocrinology in 2021. This was a study performed in Lisbon. They also include lesions with less than 3 centimeters eligible for AS, but here they included lesions with aggressive histology. They had 89% of 89 patients in the cohort, and they applied a different criteria for disease progression. They applied the RECIST criteria, an outcome that was met by 49% of the patients, a higher rate. And just to remember, these are the criteria for disease progression applied in the RECIST. The patient need to have an increase in 20% in the smallest diameter of the lesion, or local invasion, or new suspicious lymph node, or new cervical sites, new sites of metastasis. Moving to the last study that we will comment here. This is the Argentinian study, a study published by Jurkovic and Pitoya in Thyroid 2022, a study performed in Buenos Aires. They included lesions smaller than 2 centimeters. They had 50 patients. They applied the primary outcome of growth larger than 3 millimeters and had a median follow-up of 29 months. And 24% of their patients met the primary outcome. And they performed a multivariate analysis showing that patients who had thyroglobulin increase larger than 0.5 nanograms per milliliter were independently associated with the disease progression with our odds ratio of 16.24. And they also showed that these patients with this variable had a shorter progression-free survival. Here we compare all of these studies, including ours. only one of the studies did not perform fine needle aspiration routinely, and only the Portuguese study included patients with aggressive histology. You can see that the criteria for disease progression was heterogeneous between the studies, and the disease progression rate was different, varied between 20.5 to 49.9 in the Portuguese study. The rate of surgery after active surveillance was lower than the disease progression rate in all studies, except the Japanese study. And only our study reported the surgical outcomes. So when we made this comparison and discussed these other studies, we came out with the idea of make a systematic review and meta-analysis. This was the effort of our thyroid team, in special Dr. Anita Lavarda-Scheinpflug. This study was published recently in the Endocrine, and I will highlight some of the major finding of this study. Here we show the pool proportion of the disease progression following the study definition of disease progression in active surveillance of cervical metastasis, an outcome that was met by 134 patients of the 486 of the studies, resulting in a pool proportion of 28%. We had a high heterogeneity with an I-square of 82%, probably due to the different criteria applied for disease progression in each one of the studies. Coming back to our study, we had some limitations, such as the small sample size. We had a short follow-up, the retrospective nature, which ends limiting the conclusions of the study, the fact that ours is a referral center, and a lot of these patients came to us after the initial treatment, so probably the initial treatment was heterogeneous between them. And also the definition for disease progression, we address this factor as a limitation, because it ends up limiting the comparability to the other studies. And our take-home messages are that active surveillance appears to be a safe management strategy for cervical metastasis, aiming to avoid unnecessary surgical morbidity, and considering that in most cases there is no cervical disease progression. And also our surgical complication rate was low, suggesting that postponing surgery does not increase the risk of morbidity. Thank you. We will move on now to Professor Scheffel discussion.
Thank you for an excellent presentation. Just to say to the audience, you can send us your questions, and after the next presentation, we will have a Q&A session. Now, Dr. Scheffel will present his approach to the topic. Dr. Scheffel, the stage is yours.
Thank you. Thank you so much. Good morning, everyone. We're really honored to be here to discuss our data and our experience on active surveillance. As Dr. Walter already talked, we have this new study of his, and we also have some insights that we published in Archives of Endocrinology and Metabolism, and that I and Dr. Dora wrote about this topic after the publication of a study of Chile of active surveillance. And I think that we are discussing here a new paradigm in thyroid cancer that is less is more. So we are in a minimalist era of DTC, and I think this affects all the DTC approaches since the first surgery, like lobectomy or thyroidectomy, and also the active surveillance for primary tumors, and now also for cervical disease. So, as we already know, active surveillance for primary tumors is now the gold standard, especially for those patients with small papillary thyroid cancer, all these patients with microcarcinoma. We have a lot of data from the Japanese centers, also from the South Korea, some data from Latin America also, and also from Brazil, and a lot of data from US. And I believe that the next guidelines of American Thyroid Association will have this more strongly recommended. And as we just see in Dr. Walter's presentation, we have some data also on cervical disease. We have to be aware that these studies are small studies, single-center studies, retrospective studies. So this is different from that we have from primary tumors. But as you can see here, and as you can see in Dr. Walton's presentation, you have data showing us that most of the patients will not progress under active surveillance, and those patients that progress can be go for surgery without any problem with the surgery itself. I believe that one point that is crucial for active surveillance for primary tumors and also for cervical disease is the selection of the patients. So in primary tumors, we already have tables like that we can divide the patients in patients that will be ideal, appropriate, or inappropriate for active surveillance. And these definitions we do based on nodule characteristics or tumor characteristics, patient's characteristics, and medical team characteristics. I believe that we have to move to something like this for cervical disease also. And when we look for our selection criteria, we can see that we have here some patients and tumor characteristics as we do in primary tumors. Some questions about the tumor characteristics, like the size and where the cervical disease is. And also we have the aspect of the medical team characteristics, because we are in a referral center, and all the studies in active surveillance cervical disease were done in referral centers. But when we look to the studies, we can see that we have a lot of different criteria for selection of or for exclusion of those patients. So we don't have yet general criteria as we have for primary tumors. And I believe this is something that we have to elaborate and have more studies, especially prospective studies, to define those patients that can go for active surveillance cervical disease and those patients that cannot go. Finally, I think that we have to think that probably active surveillance for cervical disease probably will be more relevant than active surveillance for primary tumors, because those patients that are ideal for active surveillance for primary tumors are those patients with nodule less than 1 centimeter in size, and those patients probably should not have been diagnosed at all, since we do not evaluate cytologically the thyroid nodules that are less than 1 centimeter. On the other hand, as Dr. Walter already showed, most of the patients that have cervical disease are patients that have cervical disease before. So are those patients that have multiple cervical surgeries. And in this scenario, I think that active surveillance will be more relevant for the patients and for the systems, for the health systems, because we are preventing of doing surgeries in those patients that have already a lot of surgeries in the neck. So I believe that active surveillance could be a safe management strategy for cervical metastasis, especially for those patients that have a lot of cervical disease and a lot of cervical surgeries before. But I strongly believe that we need prospective studies to outline better the selection criteria and also to lay out a comprehensive protocols for taking disease progression. So we have to define better those patients that we will select for active surveillance and how we will do active surveillance in these patients. I will just finish with an invitation. We will have ETC in Rio de Janeiro next year, so we'll enjoy if you can see is here. And thank you very much.
Thank you, Dr. Scheffel, for the insightful discussion, and no doubt the images that you showed right now is very tempting to come to the meeting. So we have now some time for Q&A. I want to ask the first question, which is, what about when we measure the lymph node, should we look at the long axis or the short axis? That's something that I get questions all the time. So what do you think, and what did you find in your study?
We had that discussion initially, and we chose to go with the larger lesion. We know that some data previous from including other type of primary tumors applied the smallest diameter, but our question was between the volume of the disease or the larger lesion, and because a lot of studies previous from ours chose the larger lesion, we also ended up choosing the larger lesion. But I believe that is also a question. The same question you can ask yourself is how to define disease progression using the increase in the large diameter or in the volume or in the smaller diameter. Is the same question.
Right.
We have the same question.
I see Dr. Erkin is with us. What do you think?
I'm going to let you keep running. I've got my own.
Okay. So we, the study that I did in 2012, we used the largest diameter, and then the ATA guidelines recommended using the short diameter. It's pretty confusing for people who are not thyroid cancer experts, and most people look at the long axis. But we don't have enough data to say which is best. Probably volume would be best.
Yeah.
But many times we don't have three-dimensional measurements for all the ultrasounds that the patient has.
Yes.
Okay, so we have some questions from the audience. A question from Maya. She says, these are great talks. What is your opinion regarding active surveillance in other histological subtypes, such as hurdle cell carcinoma, follicular carcinoma? She's not suggesting aggressive subtypes, but these hurdle cell and follicular carcinoma.
Okay, maybe I can answer. Most of the data that you have, that is not a lot of data, as you can see in the presentations, are in papillary thyroid cancer. So I believe that hurdle cell probably is different. Oncocytic, we know that is a different kind of tumor. So I will not go for active surveillance in those patients. But in those patients with follicular low invasiveness, I believe that they are similar to papillary thyroid cancer. That I believe we can use this data. But again, for all patients, I think we have a lot of studies, but all of the studies are small studies, retrospective studies. Even we have the systematic review and meta-analysis. We know that we have limited data. So I think you can offer this for the patient. This is an option, but we have to do this with care, because you don't have data like active surveillance for primary tumors that we have 30 years of experience. I think this is something that is going on. So we need to have some case on this. And from those patients, especially for oncocytic, I will not propose active surveillance.
Yeah, I agree.
I agree with Dr. Scheffel, and we do not recommend active surveillance for aggressive lesions. In our study, we had 2 patients with follicular thyroid cancer, but it was a low-risk cancer, and we have also unpublished data of active surveillance for medullary thyroid lesions, cervical lesions. We have almost 7 to 8 patients, if I'm not mistaken, and we have a good result with medullary thyroid lesions, patients with low calcitonin levels, and without metastatic distant lesions, right?
Yeah, that's interesting. I think the oncocytic type, the oncocytic cancer can be grouped in the high-risk tumors because they tend to grow and they tend to invade the capsule of the lymph node, and they are more problematic. We have another question from Maya. What about active surveillance of lymph node metastasis during pregnancy? Do you have any data about that?
I don't know any data about pregnancy and active surveillance. Do you know any, Dr. Walter?
No, I don't, and I don't have any experience.
Yeah. So in real life, sometimes if there's a lot of disease during pregnancy, we would send for surgery, but most patients, we just follow them during pregnancy if we find a lymph node metastasis, and usually it remains stable. So that's our experience, but it's not published. We don't see different behavior. Usually in a non-aggressive tumor, we don't see a different behavior usually. So another question, if we know the mutation status, sometimes we have specifically a BRAF mutation. Today with molecular markers, sometimes you know the status, sometimes you have immunohistochemistry, and you know it's a BRAF positive tumor. Would that change your approach? Would that exclude patients from active surveillance? What do you think?
So we don't know the mutational status of most of the patients here in Brazil because you don't have the test, or the tests are very, very expensive.
Yeah.
In research, we have done something about BRAF some years ago, and we couldn't find any correlation with BRAF and aggressiveness, as most of the studies have. So I believe that this will not change our management of the case. Maybe TERT mutation, if you have some, I believe that is more that you have to be more caution about that. But with BRAF, I don't believe that you have changed anything. But we don't have this data because here in Brazil we have a lot of questions about access to mutational data. But I believe this is another question that is important. As I mentioned, I think the selection of the patient is crucial, and we are doing this. We don't know the selection criteria ideal for these patients. I think this is something that we have to work together to create a protocol that will apply to a prospective study, and then we have maybe we have these answers.
Okay, another question from Dr. Chen. What about size of cystic lymph nodes? How do you follow these lymph nodes, and do you apply the same criteria for follow-up?
We did not evaluate the cystic component of the lesions, but in our practice, it does not change the strategy.
Yeah, we treat this like a lymph node. We just measure the lymph node with the cystic part included, so we did not analyze separate cystic lymph nodes.
Yeah. Now, sometimes you have lymph nodes which are almost completely cystic. In this case, you can also consider other, like ethanol ablation and things like that.
Yes.
So sometimes you see just fluid accumulation. It's not necessarily growth. You need to see if you can find a solid area in the cyst to see if there's real growth, it's just fluid. We would try to do like a local treatment, let's say ethanol ablation, instead of repeat neck dissection just for something that is really cystic. But many lymph nodes have a small area of cystic component, right? This is what you mean, that you just measure it like anyone.
Yes.
Anyone.
I myself revise all the images, and we have only solid lesions with small components of cystic proportions, very few areas of cystic area.
Yeah. Okay, let's see more questions that we have. Okay, what about for active surveillance in the lateral neck versus the central neck? Any difference in your opinion?
That is a good question, and in our data we did not show any statistical difference between the lateral lesions and central lesions, but the rate of disease progression in the lateral lesions was higher than the central lesions, but it was only a tendency, not statistical significance, and we have to consider the surgical complications, the possible surgical complications of central versus lateral surgery. But for lesions that are eligible for active surveillance, I do not believe that if they are in the central neck, they should change the management, except if they are too close for any noble structure.
Okay. Now, when we see a lymph node, a suspicious lymph node in the lateral neck, many times it's not recurrence. Many times it's just persistent disease. Sometimes you have like a lymph node behind the carotid and all these places where sometimes they are not seen during surgery. So how many of your cases in the study were persistence and how many were true recurrences, like no evidence of disease and then new lymph nodes?
That is a great question, and we ask ourselves and discuss this topic several times. Unfortunately, we could not give this information or have this information because a lot of these patients were referred to us after the initial treatment, and it's even controversial to define what is disease what is cervical versus cervical persistence versus cervical recurrence. I believe that you should have an initial treatment, perform ultrasonography, have no lesion, and then after at least 6 months, perform another ultrasound and have a new lesion that now you can say it is a recurrence.
Right.
But in fact, it will not change our treatment. We do not will offer AS or not if it was persistent or it was a recurrence.
Right. I completely agree. Many times it's hard to say. Dr. Erkin has a comment or a question.
Yeah, and I'm going to speak for both myself and Dr. Shahab. We're both surgeons, and we tend to think of the world in perhaps more simplistic ways here. It's cancer, it's not good. I guess part of this is whether you have a perspective, and part of this is actually to try to shed some light on disease progression. But my first question is, do you have a perspective on why disease in lymph nodes develops, progresses to a point, and then remains dormant? Do you have thoughts about this? Do we think this is the same pathophysiology as what's happening in disease in the thyroid that is under active surveillance? That's my first question. Then there's a follow-on to that.
Okay, this is a great question also. I believe that we are looking for, as Dr. Robinson says, that we are looking for disease, not disease recurrence, but disease persistence, probably. And that's because I believe that is the most of the patients do not progress, because that disease probably is there a few years before, probably in the first surgery. And I believe from the point of view of a surgeon that if you have a patient that you really see disease progression and this patient can be cured with surgery, probably this is the best way to go. But here, maybe we're discussing those patients that have cervical disease that have a lot of surgeries and have a lot of morbidity from these previous surgeries. Then maybe this patient is a patient that have a disease that cannot be cured by surgery, and this patient is better to go for active surveillance. So I think there are two populations. And the first one is patients that have a progression and can be cured by surgery. And this is one population. And another population of patients that have cervical disease, that is a stable disease, and probably the disease is there since the first surgery, and maybe those patients better go for active surveillance. I think you have to try to separate these two populations. And some about pathophysiology. I think that also there are two natural history of the disease. To have the natural history of the progressive disease, and then have natural history of those patients that have a stable disease since the diagnosis.
So
I'd like to add something. Most of these patients were treated with radioiodine.
Yeah.
Sometimes it works. And growth arrest is something that we know very well in thyroid cancer. That's why we don't rush and treat micro-PTC. And so this is something that we know, that it started from knowing that these lesions remain stable, and then active surveillance was introduced. So, and Ashok was one of the founders of the of the concept. So we know it behaves that way, and radioiodine probably plays a role, at least in some of the patients.
So if I could just do a follow-on question, and in part, we know it happens, so the question is in part why. And in your study, you had two interesting cohorts. One is the patients who showed who had lymph nodes that did progress and were operated on, versus patients who had lymph node metastases that did undergo surgery because they did not want to undergo active surveillance. Can we glean anything from what the microenvironment within that lymph node showed in those two populations? Is there an intensity of immune response within the lymph node that's different for patients who had stable disease versus those who had aggressive, or is this more who showed progression? Is there anything that can be gleaned from looking at those lymph nodes histologically here?
Well, I believe that there are, in fact, some factors related to the microenvironment. We could not evaluate that. I don't know of any previous data showing that, but I believe that is plausibility criteria, plausibility for this, biological plausibility. And I really don't know, but I believe that there might be, yes, there are some histology factors such as invasion of the capsule that unfortunately we cannot evaluate with ultrasound. But if we had that information in advance, I believe it will change the treatment of these patients, and this is a point to look forward.
I think this is a great idea to look of those lymph nodes that progress and those lymph nodes that not progress histologically, maybe with immunochemistry, looking for leukocyte infiltration. I think maybe this can answer some of the questions why some patients have progression and why some patients will be stable. But we didn't do this in the study. But I think this is something that probably will answer some of these questions.
Great, thank you.
Okay, so one last question. You had one patient with distant metastasis. And if we had someone on the panel who's really, really, really against active surveillance, he would say, okay, here you had a patient, active surveillance, everything looks nice, boom, he had distant metastasis. So you shouldn't do that. What do you think of that?
Actually, this one patient already had distant metastasis. We do not exclude patients with distant metastasis from our study. And this was a patient that even with distant metastasis, we ended up including, maybe it was patient preferences. And this one case, we did know of this distant metastasis. No one of the other patients had a new diagnosis of cervical distant metastasis. So I believe that if I'm not mistaken, we had only 3 patients with high risk of recurrence, and one of these patients, it was this patient. And I believe, as a general criteria, active surveillance should be offered for low risk patients.
Okay, so thank you for a wonderful discussion. As we approach the 9 o'clock hour, I want to take a moment to thank our guests for their insightful presentation and lively discussion. Before we wrap up, I encourage everyone to visit the TIRO website, TIRO.expert, and for more resources and updates in the field of thyroid cancer and thyroid disease. Next week, we have a tumor board moderated by Dr. Mike Tuttle and with cases presented by Dr. Amy Chen. Thank you for tuning in, and special thanks for Dr. Walter and Dr. Scheffel for their contribution. Have a lovely weekend, everyone, and see you next week.